Okay. So hopefully that dinging wasn't too loud, Avalon. So just so you guys know, that presentation was very thorough and wonderful, and that's kind of what I'm expecting. If anyone wants like a good example of what your presentation should somewhat look like, that was great. You hit all the points. So that's kind of the caliber of what I'm hoping. You just have a nice round. So that was a great example of what I'm hoping you guys, and that's, I think I laid it out in the rubric pretty good. So I think it hopefully is easy for you guys to build it from off of that, but very good job. But that being said, I'm only going to have one question on pregnancy on the exam, and it's going to deal with medications or things that a pregnant woman may ingest and whether or not it's safe or not. So it's probably going to come off of more specifically my PowerPoint on pregnancy that's in Moodle, along with there's the diabetes and then there's the pregnancy. So just look at the oral health things that we offer our patients for controlling bacteria and preventing cavities, and also look at medications as well. But that's basically where the question is going to be directed on the exam. Yeah, Miranda? Oh, I hid it, but I'll unhide it. Yeah, sorry. I forgot. I hid it. So that's, and I may do something for everybody's presentation. If I have a PowerPoint that supports your topic, I'll kind of give you guys because like everything Diana and Janice talked about, super important as clinicians. You need to know that stuff as clinicians. Now, you also want to know what you need to know for your exams. So I'm going to try and say, like, you know, for when someone comes up here and does a presentation, if there's enough time and I really love some points they hit, I'm going to make sure that you guys pay attention to that for an exam, possible exam question. So I'll try and give you guys stars and heads up about what to pay attention to, because I know it can be a little confusing when you're watching a student presentation. Is that what I need to know for the exam? Because I know that's always a concern. The rubric is a Google sheet that I shared with you guys, so I can re-email it, but I had sent an email at some point where I shared the rubric, and it probably said like special needs presentation rubric or something. So you just maybe search your email, but I can always reshare it or resend it out or whatever. I thought there was something else that I was going to say, and now I don't remember what it is. Oh, I think possibly next week we have the first exam. Is that correct? Am I remembering? So just as we'll come in, I don't think I'm doing any lecturing after it. Anybody remember? I think it's just the exam and then that's it. You guys? Huh. I hate to get out of this screen. I'm in a screen right now and I don't want to leave. If I have to cover a little bit of material, obviously I have to stay and listen. But if I'm not going to cover any material, then you're free to go right after. If you get done early, just leave the room or stay here and be very quiet. I just don't want any of like the whispering or that murmuring, because it is very distracting to people who are still trying to concentrate. So if you're done with the exam, just either leave, you can take your stuff and go hang out in the hall, or if you want to sit in your seat, you can just sit there until. But I did want to make sure that I said that before the exam. I'll probably remind you guys. Okay, so we're going to talk about diabetes. So here, and this is all very review. I mean, at this point, you guys have learned about diabetes and oral med, you learned about diabetes and medical emergencies. So really the bulk of this presentation is review. And then there's like 2 slides or maybe 4 slides that talk a little bit about, kind of application and like hands-on how you might alter care for your patient. But a lot of that back information that you've already had is important to know how to apply to a current appointment that you may have. So it is very redundant, but in some ways that's good because this isn't just all brand new stuff that you need to know. So diabetes is actually a group of disorders characterized by hyperglycemia, which we know is like high levels of blood glucose. And it results from a couple different things going on in the body. It's either there's no insulin production, or they're insulin resistant. They're just not using the insulin very well, or they're not producing very much of it, or a combination of it. Yeah, I am, but just let me double check. Yes, I am recording. And then things that kind of lead to complications with that chronic hyperglycemia is sort of damage to the nerves or blood vessels. And so we call the nerve damage neuropathy. And then we call the damage to the small blood vessels microangiopathy. So like it's damaging the nerves and the small blood vessels. And so that's going to affect the patient's eyes. Their kidneys are a big organ that can get damaged, heart disease, and vascular issues as well, atherosclerosis and things like that. So what's our role? As dental hygienists, we can do a lot of educating, talking to our patients about encouraging them to do everything they can to stabilize their condition, bringing awareness to them about what their blood glucose levels are. They just might be one of those patients, especially if it's type 2. If it's type 1, chances are they're pretty like on it because they know it's such life and death scenario. But when it's type 2, sometimes they can be poorly controlled and not really feel the effects yet. And so we can help them kind of advocate for why they want to try and keep it under control and avoid those long-term problems that they would have if they just kind of have this chronic hyperglycemia. So we play a key role in managing their oral disease, also teaching them about that bidirectional relationship between diabetes and periodontal disease and oral health. And so we can really help impact their metabolic control significantly. If we talk to them about all those things, we can really help them keep all those things in check. We also wanted other things here on the slide. We want to help minimize potential risks for medical emergencies. If they're hyperglycemic, they're a risk for one type of medical emergency. We want to help detect those who are either undiagnosed or not controlled. And then we might need to modify our treatment because of, whatever, if they shouldn't be seen because they're uncontrolled diabetes. And then we want to evaluate their progress. They might not respond like we think they should. After we do scaling and root planing, we might not see the kind of results that we think we should see. And so that might lead us down different paths in helping them with their overall disease status. So pre-diabetes is kind of a problem. There's last numbers off of, I don't know if it's the Diabetic Association or one of those main pages, or if it was off the CDC, but last numbers that I got from 2015, 88 million Americans diagnosed as pre-diabetic, which is pretty hefty. It's also called impaired glucose tolerance or impaired fasting glucose when they go in and they take those different tests and they read kind of high, but not high enough to throw them into diabetic, but it's higher than normal. So then they're in this kind of pre-diabetic area. And typically they don't have any symptoms. So they can be walking around feeling just fine and be pre-diabetic. And that's the time when they really need to know about it and try and get control over it so that they don't turn into full-fledged diabetes. And again, we're kind of focusing on type 2, not type 1. But that's why we want to help kind of know the risk factors, educate the patients, help them get screened for it, encourage them to adopt more healthy behaviors for their overall health and for their oral health as well. See if there's anything here that I'm missing. So yeah.
For hypertension, is that maybe compounded by hyperglycemia or hypo? Or...
I think it's probably hyper because that's typically what tends to be the problem. is the hyper. And so I think that goes with that blood vessel damage. And then, yeah, so that's the things there. Okay, so type 1 diabetes, smaller portion of the population with type 1. They used to call this, just juvenile diabetes because it usually didn't come on later in life so much. But I guess it can. There's a lady in my church who she just became like type 1 diabetic and she's 50. But sometimes they think that actually has more to do with chemical agents and medications and stuff sometimes, or like a virus. But anyways, typically they used to call it juvenile, but now it's type 1 diabetes. And it generally presents during childhood or adolescence. And you guys remember from oral med, the beta islet cells. Did I say that right? Did I remember it right from oral med? They just stop functioning, right? The cells in the pancreas just kind of go kaput and they just stop producing insulin. And so they are dependent on insulin for the rest of their lives. Type 1 diabetes I'm just reading my notes, is a condition characterized by high blood glucose levels caused by total lack of insulin. People who develop type 1 diabetes are rarely obese. Usually they're thinner, and that's because of the diabetic ketoacidosis. That whole stasis in their body doesn't necessarily have anything to do with the lifestyle issues that we find with type 2. Research studies suggest a genetic origin is associated with type 1, but also with type 2. And then they've done studies where they've looked at twins, and if one twin is diabetic, the other twin is usually like 50% just as likely to develop diabetes. So that's where they get that genetic component. So what was I saying here? Oh, this was just talking about, we'll talk a little bit about the application with different ways people can administer insulin in a few slides. So type 2 diabetes is by far the most common type, and this is really more of an epidemic at this point in America. And it's even to the point where children, like it used to be, I don't know how many years ago, 20, 25, I should probably get some better numbers on this, but it used to be like 65 and over, that's who got type 2 diabetes. And they usually, had specific lifestyle characteristics that were sort of markers. And then there was that genetic factor. And it just has gotten younger and younger and younger until we have 10-year-olds, 8-year-olds, 10-year-olds, 15-year-olds with type 2 diabetes. So it really has become an epidemic in our country, which is really sad. 90 to 95% of the population. And then it's, we know that it's by and large preventable, and a lot of times it's lifestyle sort of driven. And so these are some things, but I listened to a patient, I was listening to a podcast. I might've already told you guys this. I can't remember who I told this to. But I was listening to a podcast where a patient with diabetes, person first language, she was talking about how the role of dental hygienists and how from her perspective, she felt like she was already bombarded with all the information all the time. Every time she went to her doctor, she felt like lectured, and this is, you're like naughty patient, your blood glucose is always so high and all this kind of stuff. And so when she came to the dental hygienist, she felt like, you're not a diabetes expert. And so it was like this completely kind of almost negative perspective of going to the hygienist and not wanting to be. So on this podcast, they were kind of saying, we have to be very sensitive when we talk to them about the lifestyle choices. And it really made me think, and I was like, boy, how do you kind of do that? Because it is so important. It's so directly affects their oral health. And we already are kind of talking about, lifestyle choices and how it affects rates of decay and all this stuff. So I think it comes down to your delivery and your intent. And I just think you're always going to come across people that are like, don't lecture to, you tell people to floss and they'll tell you not to lecture. No, don't lecture me. So it really comes, you just have to think about how you deliver it to your patient and what your motivation is. You're doing it with nothing but care for their overall health, and ask them questions about what they've already talked to their providers about. Say, what does your provider tell you every time? So then you're not just repeating, you're finding out where the missing gaps are. Like, what are the gaps that they're not getting? And if you kind of go for it in that way, they might not feel so bombarded, I guess. But it just threw me. I was like, wow, like it was almost like I felt like they were saying, don't talk to me about my diabetes. You're just here to clean my teeth. And I was like, absolutely not. But at the same time, I'm sympathetic. I kind of understand. So totally went off on a tangent there. Risk factors. So these are the risk factors. We know they're pretty well known as far as what increases the person's risk for diabetes. But somebody can have diabetes, be full-blown diabetic, type 2 diabetic, for up to like even 10 years, they say in studies, without knowing. Or, they might just not be in tune with, optimum health and their body, and they're just kind of like, I'm fine. And until something really resonates, where something is really starting to come to the forefront, that they start to notice that there's actually something going on. So up to 10 years, they can have this brewing and causing a lot of, it's like hypertension. It's like they call it the silent killer, because people can live with it for decades and it's doing damage, internal systemic damage. Okay, predominantly genetically inherited, and it has no association with autoimmune beta cell destruction. So very different from type 1. Gestational diabetes, I'm going to kind of skip over it because you guys did such a beautiful job talking about that. But for our Zoom member, I'll just say that it does increase, they have found that it does increase your risk of having gestational diabetes in future pregnancies. And then also you have an increased risk of having just type 2 diabetes later in life. If you have experienced gestational, it increases your risk. Yeah.
So I had diabetes.
Oh, yeah.
Had diagnosed type 1, undiagnosed type 2. They just gave them medication to see if it helped with the but they were saying that they think he's type 1.5.
Really? So
can we talk about that?
Okay.
I don't understand it.
I don't have anything of knowledge to tell you, except my friend at church said that when she was diagnosed, they're like, we don't know what you have. You're diabetic and you're somewhere between 1 and 2, more like 1, less like 2.
Taking insulin, but like, even though he ate that morning, he's
very, yeah, very strange. I feel, and I was talking with Teresa about this, and she said that her husband had a little pre-diabetic he's always been fine, and all of a sudden his doctor, well, and oh my word, I'm totally saying HIPAA stuff. Okay. Let's just rewind, pretend I never said anything, and then I'm just going to say I have talked with people in the past, and so the doctors have been noticing more of an increase in this. So something is changing in the landscape of diabetes. I'm not sure what it is really, but I've heard many interesting things. And through the years, things like that, I guess happen. I don't know. But interesting. I don't know what somewhere in the middle means. I really don't. But I have heard other kind of strange things regarding like pre-diabetic states and things like that, and diabetes that are kind of hard to diagnose. So that's new. And there's nothing in the textbook on that. And there's probably not any studies on it yet either. So very interesting. Okay, next, moving forward. So then this just touches on it. So this is that others, I guess, other types of diabetes that they don't know what category it falls into. Sometimes it can be because of pancreatic disease, endocrine disease, this chemical induced agent, like this is what my friend thinks potentially happened, and then genetic syndrome. So there is this sort of other area that is probably still being studied. So I pulled up, this is just from the clinic manual. You guys need to know this obviously every day when you're in clinic. So I just thought we would just review this together. The glucose testing on patients, you do this when when you suspect your patient is pre-diabetic, when they say something about having a positive health history. Even if they say, no, no one has ever told me that I'm pre-diabetic, or no, I don't have diabetes. If they mark health history of diabetes on their health history, it is not a bad idea. You are doing them a service to screen them and do it. And I know it's like, oh, I don't want to poke my patient, and but it really is. It's probably the best thing. It's like taking their blood pressure. If they never have it done anywhere else, then you're really doing them quite a good service. A1C, HbA1c is stands for the glycated. Is it hemoglobin? Glycated hemoglobin. That's the HbA1c. We always just shorten it to A1C. Controlled diabetes is usually right around 7. And so that's why we say if they have controlled diabetes, their A1C is on record, then we'll go up a little bit higher to 250. But if we have no A1C on record and they are up to 200, that's hyperglycemic. And that puts them at risk for a couple things. So that's why we don't see them. So we delay treatment, we refer them to a physician, especially if we take it and they are up here in the 300, then it's like, oh goodness, you need to go now, because that's really significant. And they need medical clearance before you can see them again. Yeah, Megan.
So I actually have a patient, she's diabetic, and she, so I was like, I'll send those, well, just eat.
Yeah.
And it was like over.
Yeah.
When I took it.
Yeah.
And it was interesting because I went around and I walked with her and I calmed down and her physician learned to give parents a good.
Yeah.
She was like, oh yeah.
You're fine. So that's a kind of a similar thing for when, like, I've heard patients that have gone to their doctor because of concern of high blood pressure, and their high blood pressure will be like, 145 over 90. And their doctors are like, that's fine. And I'm like, but that's high blood pressure. Shouldn't you give them some lifestyle advice at least? I mean, like, you don't want them walking around. But I think healthcare providers get so used to seeing these out of control numbers that I think that this is just my guess, is that sometimes there can be a bit of desensitization. It's like, we can't get it any better than that. That's just them. You know what I mean? Like, I don't know if that's true or not, but I almost feel like that happens sometimes. And I know some people are harder to control. Like, they just have same thing with blood pressure. It can be very hard to control it. So kind of crazy. All right. So here's just the guidelines. This is from your textbook. This is for the A1C. This is fasting plasma glucose, and what's OGT? I just said it too. Do I have it written down? Oh, oral glucose tolerance test. So one is like, you just go in and you like fast and you drink. I've had them both, and one of them is really bad. The one where you fast for like a really long time and then you drink a ton and it shoots up your blood glucose. Oh my gosh, I was so shaky. I was like, feels really bad. Yeah, the one where you just go in and they just give you, like, you've eaten recently and they give you, that one I've had every time I'm pregnant, and that one wasn't so bad, but then I had the other one that was bad. Anyways, these are just the numbers. This is the A1C. So once somebody is above 5.7, then they're pre-diabetic, and if they are above 6.4, that's the threshold for diabetes. So that's why you can see that if they're diabetic and they're at a 7, that's like a well-controlled diabetic. If they get much higher than that, we don't like that too much. You don't really have to memorize them, but it is good to know. It's good to know like the 200. It's good to know that normal is like 80 to 120. So it's good to know what normal is. Below 70 is hypoglycemic. It's just good to have those numbers in your head as a clinician. Knowing that on average 7, if they're a diabetic, 7 is a good place to live for a diabetic patient. That's kind of good to just know that information. And I guess it could be on an exam, trying to think if it was on an exam or not. Yeah, it's good to know that. So just as a reminder, insulin, it's an anabolic hormone that's secreted from the pancreas, and it's used to help glucose. It's like the key, right? It's used to help glucose enter the bloodstream. Otherwise, it carries it in, basically. Otherwise, it can't. So without insulin, glucose remains in the bloodstream. It gets it from the bloodstream to the cells. I said it wrong. Rather than just living in the bloodstream and causing hyperglycemia. So we need it to get out and into the cell so it can actually give us energy and do all the things that glucose is supposed to do. Here's a chat. Hold on just a second. Sorry, Avalon, I missed your chat, but you got it. You got it answered. Oh yeah, she was saying the same thing. Okay, sorry, sidetracked there. All right, so one thing you guys are going to want to know, this term could be on the exam. So the term cardinal symptoms. So it's like there's a few things that are they call them the cardinal symptoms of diabetes. So if you have a patient in your chair that doesn't know that they have diabetes, or maybe they've been pre-diabetic for a while, and then all of a sudden they're starting to, it's starting to get worse, and they're actually creeping closer to being true diabetics. There's a few things that you might notice. Some of the biggest ones is this, when I was in school, they referred to it as like a rotten fruit smell. They call it fruity acetone. And I have smelled that on my patient's breath before. It's not perio breath. It's very different. And actually, it's almost like, did they just drink alcohol, or is that fruity acetone that I was told about? It's like, you're seriously not sure, because I kind of think they smell a little similar, but it's prominent, and you kind of feel in this weird situation because you don't see it every day. So you're like, should I ask them? And that's when you want to ask them about their family history of diabetes, if their doctor has ever said anything about them being pre-diabetic, because chances are that their doctor will have said something if you notice something. If they frequent urination, excessive thirst, unusual hunger, those are all some pretty good cardinal signs. Just for your information, polydipsia, these are terms that might be on like a board. They love throwing these terms in, So polydipsia is increased thirst, or like a great thirst. Polyuria, frequent urination. Polyphagia or phagia is excessive hunger. I always think I say that, but I think of dysphagia also, and like difficulty swallowing. So like, anything going down the throat, kind of reminds me of aphasia. So those are those 3 poly words that they love using those on exams. And then there's other ones here too, but this fruity acetone, frequent urination, excessive thirst, unusual hunger, those are some pretty common first, like when they're in like almost like a diabetic kind of crisis, like things are really increasing. Those are some of the signs and symptoms. They're like the cardinal signs and symptoms. Okay, so some chronic complications. We talked about, there's the micro and the macrovascular disease. These can lead to things like the diabetic retinopathy that can affect their vision, and the severe cases there. Did you have a question, Jen? Fluid retention. Well, that would be probably because their heart's not working well enough, and it's not being an effective pump. And so I think that probably has a lot to, and it affects the heart. So that's where you get that cardiovascular complication from diabetes, which then could be what's happening with swollen ankles. Neuropathy leading to renal failure, all the tiny little blood vessels coming in and out of the kidneys. There's tons of them, and when they get damaged and the kidneys can't filter so well anymore. Peripheral neuropathy, the foot ulcers, they don't feel their feet, they don't feel injury. And so they'll have a sore or something. and they'll just ignore it until it's like really bad infected, and then they might lose part of their foot or a toe. Autonomic neuropathy, so then they can have other nerve damage in other areas like gastrointestinal, the urinary tract, cardiovascular, or sexual dysfunction. So any area that has any of this peripheral blood and nerves system. And then periodontal disease. We know they just don't respond as well to the treatment if they're uncontrolled. We know that they're just at higher risk for infection. They have decreased healing. They just don't heal as well. All of these things, especially when they're uncontrolled. Yeah.
I just feel like, I don't know, I was thinking about Saturday. My patients have never been diagnosed with diabetes, that's why I really strong in history. And she went and saw an occupational therapist after we had her down here. And for the neuropathy, like the joint pain and stuff, they did this test on her hand to actually test the nerves as well.
Yeah.
And it literally just took these like little like plastic fibers, and they were testing the different nerves in the finger to see if she could feel
it.
and she actually did have like diminished sensitivity in her nerves in her fingertips and stuff. And the pharmacist was saying that that's actually what's common in diabetic patients as well, and it can be a sign for family members that like they might get diabetes.
Yeah. Oh, like that could almost be like a precursor or something. Interesting. Wow. Yeah. Oh, that's so interesting. Wait, I should go to one of those diabetes clinics. Was it really good? Yes. All the interprofessional mingling stuff. I was going to also say, you guys, I am gonna just keep barreling on. And so if anyone does need to get up and use the restroom, go ahead, but I'm not gonna break because we only have 20 more minutes and I want to get through the slides. I don't know why I have the darndest hardest time getting through slides. I just have to talk faster or put less information on the slides.
I think you always forget that you go longer than you. Yeah.
Really?
Yeah.
Don't we have to go till 2:50?
No, 3:20. We start at 1:30.
Oh, yay! I was like, how in the world am I going to get through these slides in 20 minutes? I'm like, why does this keep happening to me? Oh, well then let me put it this way. I'm going to go at a regular pace and we'll get done when we get done. And I'm still not going to break because you guys just get up and go if you need to use the restroom. And I'm just going to keep going and then we'll get done early. Is anybody like that? We'll probably get done early. Unless you all really want to break, but just go. Okay, that's what I'm thinking too. Okay, so where am I? So chronic complications. So patients who have diabetes have a higher risk of atherosclerosis, cardiovascular disease, peripheral vascular disease, cerebrovascular disease, everything that the vascular system could affect, it will affect. Hypertension, abnormalities in lipoprotein, they have higher fat, but now oh my word, the phrase just left my brain. Yeah, there's the higher, although I just want to say yes, but I'm like the word is left my brain. So never mind, we're moving on. Yeah, like HDL and LDL, they tend to have the higher. That's probably what I'm thinking of, dyslipidemia. Okay, that's why. And of course, periodontal disease as well. Typically, so these are kind of the range, like if it's a patient with type 1 diabetes, they have a tendency to be more predisposed to the kidney and the eye. And I really don't know in depth why that is, but both types of diabetes can get this vascular and nerve damage. So they can have this no matter what, but these you see a higher incidence of kidney and eye disease in type 1, and then you see a higher level of heart disease and atherosclerosis and stuff in type 2 diabetes. And then you see the neuropathy in both, but you can, obviously it can show up either way. Okay, so reduced periodontal disease and diabetic patients. So the prevalence and severity of periodontal disease increases in both type 1 and type 2. So it's important for them to understand that this relationship and their increased risk. A1C that's greater than 8%, they have a greater risk of periodontal complication. And why do you think that is? Yeah. Yeah, so if they're constantly living in a state of hyperglycemia, they just have a bunch of cascading things that are, gonna make their ability to heal and fight off the condition. They're gonna have higher rates of inflammation. They might have some level of immunocompromise or just not healing as well. So all of these cascading conditions are gonna affect their oral health and complicate the periodontal disease process. Glycemic control is an integral part of controlling periodontal disease. There's just the studies, and you guys, I'm sure, have heard this in other classes, where if their glycemic blood glucose is high, they have a harder time controlling their periodontal disease and stabilizing their periodontal disease. And if they have uncontrolled periodontal disease, all of those inflammatory markers swirling around their body is making it harder for them to control their high blood sugar. So they're like, one makes the other one harder to control. So when they have both things like flaring, it's just, they're in a pickle because they just have got to get them both under control in order to help the other one. And so when your patient knows that bidirectional relationship, it really helps. Hyperglycemia leads to an increase in pro-inflammatory cytokines that destroys the connective tissue and the bone. So when they're in that constant state, when they're 8% or above, and they're in that constant state of hyperglycemia, they just have more of those cytokines floating around doing the damage. So that's partly why it's so important for them to keep stabilized. So more about periodontal disease in diabetic patients. The positive outcomes are not always typical with SRP. So sometimes, we say, oh, you have all this calculus and all this biofilm, and yes, you're diabetic, but if we just get all this under control, it's just going to look beautiful. And then we go and we do all those things that we think need to be done, remove the hard deposits, and we help them work with their oral hygiene. And we find that we didn't get the result that we think we should get. And that's because we are dealing with like a whole systemic disease process that is just really affecting their mouth. And so they may have a less than optimal results, or it might be a slower healing process that they just have to stay on top of. So we might see varying degrees. Then we always have to consider too, like, did I leave some calculus there? Is that what's happening? You just have to critically think through the process and try and figure out what's going on, but you're not always going to see these great results that you might expect. However, hard and soft deposit removal is crucial. So we still go through all these processes. Evidence does support that low dose doxycycline. Do you guys remember when we just touched on that in oral med? There's what's it called? Periostat. It's like when it's such a low, because doxycycline is an antibiotic, but in this low dose of 20%, it doesn't act like an antibiotic, it acts like an antimicrobial. And so they have found that patients, when they're given this low dose 20 milligrams doxycycline along with SRP, they have very favorable results. Yeah. It's a pill, actually. It's like a pill they take. There's also like the ones, I could be thinking of the wrong name, and so forgive me if I've told you the wrong name, but that's like oral. But then there's also, there's Arrestin, and then there's another one that's like a disc and then there's like a gel, Atrodox, and so there's those stuff that's all topical, but this 20 milligrams doxycycline is like a pill, just super low dose doxycycline, which acts, more like an antimicrobial. Antibiotic premedication is not always a requirement. I mean, if they still have to have, like, if they're super immunocompromised for some reason, I think, they'd have to probably have like a valvular issue. So it'd probably have to be like this plus something else. Or if they're very, very poorly controlled, like super, like immunocompromised for some reason, and their risk of infection is like through the roof, then they might consult and pre-med them. So I have never seen it either in real life, but that's not to say it's not done somewhere. So it's not like an automatic requirement at all. I think you guys know that. Plus, we've just recently got some updated ADA guidelines, and they keep reducing who needs pre-medication. It's like a very small window of people, but usually the crux is how immunocompromised are they, how high of risk of infection, and then what's going on like with their heart or like valve issues and stuff. Epinephrine, we do have to think about, I read a study, a couple studies actually, that didn't show a lot of effect of epinephrine with the levels of glucose in the blood. But there's also studies that say that if they are uncontrolled diabetic, to minimize or be very careful with epinephrine, because it can sort of like diminish the effects of insulin. So, but it's the same thing with stress. So we think about, we want our patients to be relaxed and calm and happy, because if they're stressed, having like a lot of anxiety, what are they producing? Like a lot of epinephrine, and they're like, oh, and so it's the same thing. So that's just endogenous, right? It's just in there, they're doing it to themselves instead of us injecting it. But we do want to think about their stress levels because of that, and be very cautious. So we have so many patients with diabetes in our clinic, and we're giving local anesthetic all the time, but we're also taking their blood glucose level. And so we know if they're hyperglycemic, we're not going to even see them. So we have a little bit, we're more kind of careful about all that. So the medications, so there's the oral, there's the injectable. Insulin may be injected subcutaneously with an insulin syringe or a pen-like device. There's the insulin pumps that are kind of programmed, or it's like a steady drip of insulin that they get throughout the day. And then there's also like a button that they can push if they need like a bolus, like they've just eaten so I guess they can either control it, or it could just be like a steady, I guess it just probably depends on the patient with their doctor and their lifestyle, how they want it to be set up. And there is a table in the textbook that kind of goes over the types of insulin and their onset and duration, because there's slow onset, there's rapid onset, there's ones that last this many hours, that, you know, short acting, long acting, that sort of thing. I'm not going to test you on that specifically, but it is important, I think, for you guys to know some of these oh yeah. Lexicon?
The one where it stays on the arm.
Oh, I don't know. I probably have to like, I think actually I have seen that, but I don't have anything on it. So I probably need to. Does it monitor their glucose level? I did see a commercial about that.
They have that will tell them where they're at, like on their
So it like beeps if they go high or something like that.
Yeah, it will be.
That's so cool. Interesting. I need a slide on that. What's it called? Dexicon? COM, Dexcom? I'll have to remember that. I don't have my notes in here. I'll just have to remember it. Yeah. Yeah, it does sound like something that maybe would be used for more like type 1, but who knows? Oral hypoglycemic agents are only used in the treatment of type 2, and we have those medications that we see a lot, like metformin, and then glucophage, and different, there's metformin is glucophage. And then, but I don't think that I have this information so much on the exam. I'm trying to rack my brain, but this, I just put these here because I wouldn't be surprised if even on the national board, there wasn't questions about like knowing the category of the bigonide and the sulfonylureas. So I just think that these are important to kind of remind yourself. Yeah. Yeah, what questions? All 9 hours worth. Can you just tell us the 9-hour exam? What questions? Oh, I know. So let's see, metformin therapy is started by your primary care provider or an endocrinologist. And it's usually started when someone is type 2 diabetes diagnosed, but it can also be, sometimes they'll do it if someone's still in like the pre-diabetes and they are hoping to like kind of prevent them from going into like the full, like full diabetes. So they might actually do it to kind of slow the progression. And many people with diabetes are also treated with anticoagulants, antiplatelet drugs, antihypertensive drugs, because we have, cholesterol drugs, the lipid lowering drugs, because again, we have all those kind of chronic complications that come with patients with type 2 diabetes. And generally speaking, this should say this note too. Generally speaking, the oral hypoglycemic agents, they stimulate the pancreas to secrete more insulin. They also increase the body's response to the insulin. So sometimes type 2 diabetes, they'll say that they just are resistant, insulin resistant. And so these medications kind of urge the body to respond better to the insulin. They can also slow glucose digestion or decrease glucose production from the liver. So those are also, and so some of those can also increase not all of them, but some of them can increase the patient's potential to be hypoglycemic if they're not careful about what their medications, when they've taken them, what they've eaten. So they still have to be on all of that and kind of monitoring their state, their blood glucose state. So process of care. So only 37% of type 2 diabetics attain an A1C of less than 7%. So I don't know if that's just because it's hard to maintain it, or it's because it's those lifestyle changes are such a struggle. It's like getting people to quit smoking. It's hard to change a pattern that maybe has emerged throughout your. So I don't know if that directly affects it or not, but that's a pretty significant, as a smaller amount. So that means that predominantly, like the majority of type 2 diabetics are closer to the uncontrolled realm, and so we're going to see more of these effects in the mouth. And infection can profoundly disturb the glycemic control. We've talked about that. So infection in the mouth, the periodontal disease infection process can disturb the glycemic control. So that can add to their inability to control their diabetes as well. Or it could be an infection anywhere else in the body. It could be like an infection in their foot or somewhere else that's causing their diabetes to just not be as stable. I don't want to miss anything. So infections of any kind can cause a profound disturbance of glycemic control, which you said potentially can lead to the ketoacidosis or the diabetic coma, which is the medical emergency we do not want to have happen. When infection is present, I was like, what is this word? I don't have a space here. But it's counter-regulatory hormone secretion increases, specifically increasing things like cortisol, so like the stress hormones, and that increases furthermore, that kind of has a cascading event to increase blood glucose. So hyperglycemia is increased, which increases the ketogenesis. So it's sort of like this kind of vicious cycle that just gets it, kind of off and running until they get to a place where their blood glucose is so high that they're in a diabetic coma. Infection is the most common precipitating factor for severe ketoacidosis in the patient with poorly controlled diabetes. There's sort of I wrote phagocytic, oh my word. It's like when the cells eat themselves. What is that? Yes, kind of a function. That function is impaired. So when, whatever breaks that down is not working out. I don't like how I wrote that word in there, and then I can pronounce it. That's great. And so, and then the resistance to infection and increased disease. So this whole kind of process, they're more susceptible to infection, and it just kind of is this cascading event that sort of leads to their instability. And then that's the one thing, you know, I think it was Professor Copeland when we were having a meeting, and she asked, is there scientific data about why we stop seeing a patient at 200 when their blood glucose is 200 milligrams per deciliter? And I was like, I don't know. I couldn't think of it off the top of my head. But it is that point where we know that they're hyperglycemic, and we just know that they're at an increased risk for this whole ketoacidosis and increasing. And if their infection is already kind of raging in their mouth, it just increases their whole likelihood of going down this path. And so that's why we kind of make that cutoff, because you have to make it somewhere. But it's so that's exactly, I think she made that point. She was like, but if they don't have somebody to like help stop that disease process, where does that leave the patient? And it was a good point. I mean, it's like right. Yeah. And then another point too is, I don't know how many of you have been in dentistry long enough and seen enough patients just knowing what's going on in the office to know how many times the hygienist takes blood glucose. But I have never worked in a practice where we took blood glucose. So how many patients did I see over my 20-year career where I don't know what their blood glucose was? And, you know, when I think about it now, I'm like, well, that's gross neglect. But I mean, that is just more common. Unfortunately, it's just more common that offices don't do it. And will that change in the future? Hopefully they'll make time to take patients' blood glucose before, but it certainly wasn't the norm when I was working. So, you know, that does, I mean, how would you ever know if you don't take their blood glucose? Stress can contribute to hyperglycemia, vitals for diabetics to understand their susceptibility to periodontal infections. So we kind of lump all of these things together, their systemic health and their oral health, to kind of help encourage them to hopefully avoid these situations, especially a medical emergency in our office. We don't want that. So when obtaining a patient's health history, the dental hygienist questions the patient about several things. You just kind of want to get their history and their kind of overview about how stable they are and what sorts of things you know, have they had to deal with in the past. Do they easily, you know, have they ever been hypoglycemic? Do they easily become hyperglycemic? Have they ever had an incident where they ended up at the hospital? So it's important to kind of get that information. And then of course we want to determine whether or not there's anything they're undiagnosed, they have any kind of undiagnosed or pre-diabetic thing going on, so we know what their risks are. So assess the risks of undiagnosed diabetes, or if the patient's at a high risk. CDC recommends that dental offices administer an A1C test. I forgot about this. Administer an A1C test or use the blood glucose self-monitoring device to screen patients. So I feel like they have the protocols at like that level, you know, like the CDC recommends it. So it's out there, but it takes a while for that to transfer to real life. It's kind of like blood pressure. Like the first 10 years that I practiced hygiene, I never took anybody's blood pressure. We did it in school, but nobody else did it around me. And so you just kind of let it go. And then at about maybe the 10-year mark, it was all the time they were talking about it in CE courses. Take your patient's blood pressure, take your patient's blood pressure. Everyone should be taking their patient's blood pressure. And so then it started to just generate it. And so then people started taking their patient's blood pressure more often. So now at this point, it's pretty common to have your blood pressure taken at the dentist. So maybe this will be similar, the A1C or the blood glucose. In the aging population, traditional symptoms do not usually manifest. So it's a little bit more under the radar. And so they also are at higher risk. In the aging, clinical findings are related to chronic complications such as vascular disorders and neuropathic syndrome. So it shows up a little bit different. So we might not see the same kinds of things in, a patient who's 75 and just acquired diabetes as opposed to, 50-year-old or 45-year-old. Here's just lots of different things to think about when you patient. So the previous slide was more if you don't know that your patient is diagnosed, or if the patient does not know, should I say, that they are diagnosed diabetes. These are some things to think about, like with assessing their risk. But this next slide is more for if you have a patient that you definitely do know has diabetes. So these are just some things that you should include in your patient interview. The decision to continue the treatment and gather the assessments. You may choose to consult the physician. You may choose to do that, and if you're just unsure, if you're not sure about where they're at, if it's safe, is it a risk to continue care? You can. I always say that, like I was thinking about that with the pregnant patients that you may have, and say whatever you come to a situation where nitrous has all of a sudden been introduced on the table as an option, and you're like, oh, I don't know, I'm not comfortable. Call their OBGYN. If they're in their second or third trimester and your doctor is like, it's fine, but you just want to hear that OB say it's fine, always feel like you can do something like that. It's the same thing with anything, any patient that you're just not sure and you just want to get a confirmation from someone. It was like the doctor, whoever said it, their doctor gave them the clearance. They were like, yeah, sure, that's fine. And their blood sugar was like 320. Yeah, it sounds a little suspect. Yeah, they're just having difficulty. Yeah, I feel like if she would benefit from the oral health care, and if her doctor gives it okay and she's okay with it, I don't know. That's kind of where I'm at. Yeah. Yeah. She might not really truly be fine on a cellular level, but maybe she feels fine. I don't know. Okay, so some things to think about. We want to talk to our patients about, we want to know what type of diabetes they have. We want to know about their what they're doing to try and maintain stability with their lifestyle choices, their timing of, when they take their medications and what they do, the diet and exercise, if they have been recommended to lose weight or do any kind of lifestyle change, if they've taken that into consideration. Their medications, their schedule, their dose. Did they take their regular medication today? Did you eat something like you normally would? All these kind of questions. We'd love to have their most recent A1C on record. How often do they monitor their blood glucose? Usually they do it every morning or twice a day or something. Fasting blood glucose levels, if they have these other numbers, they don't need all of them, but if they don't have an A1C, maybe they have a fasting blood glucose or something like that. And so just asking them for the results of those. What's their typical blood glucose level 2 hours after a meal? So if they come in and they're like, yeah, I ate like an hour and a half ago or 2 hours, you can just check to see if everything is sort of falling into the normal realm for them. If they have had any kind of hypoglycemic episode or like a diabetic emergency of any kind, and when that was and how that went, what happened, and then when their diabetes. That's a lot of questions to think of, but you can kind of boil those down into a couple questions and have it not be like this 10-question checklist that you ask every one of your patients with diabetes. But you do want to make sure that you find out their overall picture of their stability, their general diabetic state, and if they're stable. Yeah. No, I never did before, ever.
So probably not until.
Yeah. I never worked for a practice that did. We had them in our medical emergency. And then if a patient was exhibiting signs of hypoglycemia, then we would take their blood glucose and give them a cookie or something. But, and then of course, if there was, other signs of, like hyperglycemia or diabetic coma, then we, call 911, take their, so we had the glucometer and we had all that stuff there, but we didn't do it routinely. So it's interesting to me to see how that will change, because I think that it'll probably be incorporated more into what we do eventually, but it's not very common right now because it takes time and everybody's like crunched for time, It takes it probably at least 3 minutes to do it. Okay, so these are just some numbers that you should know. That under 70, too low, hypoglycemic, provide 150 milligrams of carbohydrates. This would typically be like a glass of milk or 4 ounces of orange juice or a couple hard candies. And then you can wait, and then you can recheck, and then recheck their blood glucose, see if it's come back up. 70 to 79, monitor at least once during the dental hygiene appointment to make sure they haven't dipped below that. 80 to 1, this says 149, but I had another one that said 80 to 120. So they might have raised it, I guess, kind of like high blood pressure, they adjust the numbers, but I thought it was 120. 150 to 200 is higher levels, and above 200 is too high, tendency toward hyperglycemia. Hyperglycemia, check with the physician. Risk for emergency situation. So I wrote here, like, why do we stop at 200? And it's because there's this higher risk for an emergency situation, and the patient's technically hyperglycemic. If they're 200, even if that's normal for them, just like we call somebody hypertensive, they have high blood pressure. They're technically hyperglycemic if they're at 200. So they're considered uncontrolled diabetes. And this includes the patient is at greater risk for infection. So they're at greater risk for infection and may be more immunocompromised. And so we'll generally postpone treatment until they have better glycemic control. It does beg the question, when do we get to actually care for their bacterial levels if they're always in this state of hyperglycemia? So that's kind of a complex question, which has to involve the doctor and the physician at some point if you're going to treat them in this kind of more risky, range of blood glucose. Persons with uncontrolled diabetes are at an increased risk of medical emergency, including coma, insulin shock, severe hypoglycemia. If they have taken their insulin and they didn't eat, then they're at a risk for hypoglycemia. Severe hyperglycemia, or the ketoacidosis, and non-keto. Well, I don't know what that is, so never mind, we're going to skip that. They're also at an increased risk for infection, like we already said, and then heart attack or stroke, because of all those increased risk for the different chronic infections, chronic conditions that are related to the heart. Patients or clients with diabetes are better able to tolerate transient periods of hyperglycemia. So that's why we get the patients with like 324 milligrams per deciliter, and they just are like, oh, this isn't fine for me. They can handle kind of long range chronic hyperglycemia more than they can handle hypoglycemia. They kind of live in this state of hyperglycemia, so they're more accustomed to it. But hypoglycemia can feel very uncomfortable, shaky, and clammy, and all this. Okay, I am going to give myself a 2-second break to drink water because my throat is incredibly dry. So let me pause this, and I'm gonna just run to my office and get a sip of water. Okay, I have resumed recording. Okay, so we have, most people are back. So when would you consider it necessary to contact in private practice, it might be a little bit more relaxed or maybe a little bit different than when we're here at school, because we'll do a medical consult a lot quicker at school. But in general, the times when you'd want to refer your patient to the physician or reach out to a physician is if you have noticed any of those cardinal signs or cardinal warning symptoms, and the patient also indicates that, yeah, I do have a family history, or yeah, I have been noticing. They start talking about stuff and go, yeah, I am always thirsty and whatever. So if you notice some of those symptoms that are sort of the classic signs, and then if they have gone and now if they've gone and had these blood glucose tests, the fasting and these different ones, their doctors are they're going to have done those at a doctor's office. So this is a little bit, doesn't necessarily, if we take their blood glucose and we notice it's high, but we're not going to do the fasting blood glucose. So that would have been done with a doctor. Long period since the patient was last seen by a physician. So if you notice some things and the patient also hasn't seen a doctor in 10 years, you could say, type 2 diabetes is very prevalent. It's not a bad idea to go and get screened for these kinds of things, and just give them some information and encouragement to go see their doctor. Frequent episodes of hypoglycemia, if that's like something that's recurrent for them, then they would want to see a doctor about that. Diagnosed diabetes plus signs and symptoms of diabetes for someone who isn't controlled, then they need to go and maybe have their medications adjusted. Type 1 diabetes with extreme hyperglycemia and hypoglycemia. So again, if they're just not stable, it might be something with their medication level or their, their eating. They have to change something about their diet. But then it could be something going on in another part of their body that's affecting their ability to control their diabetes. So that, like this says, an infection somewhere, if they're fighting something, it could, really impair their ability to have controlled diabetes. So they might need some tests to find out if anything's happening in their body anywhere else. I just oh no, okay. When to consult with the patient's physician. So if the patient's in your chair, when the patient has the following, if they're type 1 or type 2 diabetes, and if you need to kind of determine where they're at, then you might just want to give, if the patient is just kind of like, I don't know, and they just aren't interested, then you might want to just call and consult with them and be like, how has this patient been over the course of the last, 6 months or a year. Complications such as renal disease or cardiovascular disease, if they have multiple comorbidities, and you might want, and it just seems like they're not stable, they're on a new medication, and you just want to check in and see. It's always a good idea. If they take their prescribed insulin, lapse in good medical management, if it's been a while since they've been to the doctor, indications for extensive periodontal or oral maxillofacial surgery. So if they're about to have something big come up, it's not a bad idea to consult with the physician. So some oral assessments, these are things that you'd see in generally like poorly controlled diabetics, but you could see them other times as well, but this you'd usually see. But again, with the diet, like 37% of the population is usually well controlled. So that's a large part of the population that technically poorly controlled diabetics. Angular chelosis or cheilitis, xerostomia, burning mouth syndrome. Sometimes that they don't know what's connected or what's causing the burning mouth, but that's seen in patients that are diabetic. Enlarged salivary glands, increased incidence of lichen planus. They have higher levels of glucose in their saliva, so that also makes them, of course, more prone to decay and cavities. So that ushers in a whole different set of recommendations that we'd have. They're going to be more immunocompromised, so they're going to be more likely to have increased candidiasis and thrush. And of course, we talked about periodontal disease and then slow wound healing. So if they say they wear a denture and it wears and they have like an ulceration from the denture, they might have a harder time. Normally things in the mouth heal really fast. We always say that to our patients. Oh, the mouth heals so fast. They have a sore, it's gone in like 10 days, but it might take longer for them to heal. And of course, the xerostomia is going to double up with the increased glucose in the saliva. So that's another added thing that's going to increase their caries risk. So this is just talking about their increased caries risk because of decreased salivary flow, increased glucose in the saliva, and then they may have a partiality to fermentable carbohydrates, especially if there's that whole kind of lifestyle piece and dietary piece. They might snack, they might enjoy things that are more, along the lines of fermentable carbohydrates that are more cariogenic. So we just have to kind of keep all those things in mind. Diagnosis and planning. So protecting patients from health risk and diabetic emergencies. So these are just things we want to consider when we're thinking about the treatment, when we're thinking about how often they're going to have to come in, how long their appointments are going to be, all that kind of stuff. We want to reduce stress levels for the patient. We want to keep our appointments sort of brief, and mornings are best. They're generally more controlled. Their glycemic levels are generally more controlled in the morning. And then a lot of times people wake up and they're on their routine. They take their medications and eat the breakfast or whatever it is. And so it's usually more predictable. Appointments an hour or two after breakfast are typically a safe time, a good time to schedule them. Consider when patient took their medication last and what they ate and when they ate. SRP and periodontal debridement are contraindicated if they're uncontrolled diabetics. So if they have, we've already kind of mulled this over, but if they have very high levels of blood glucose levels and they're considered severely uncontrolled, they might be more immunocompromised, and the getting in there and rummaging around in all the bacteria and increasing that bacteremia might be a very poor choice. And so they say it's contraindicated, but I do think that in the end, it'll become a situation where the physician and the doctor have to discuss the risk benefit analysis, if you will. Lots of verbiage here. The one thing I loved about your slides, you guys, Diana and Janice, was how few words you had. This is like a paragraph. I don't like it. I'm going to change it. But these are just, I'm not going to read through them all, but they're patient or client education tips. So they're just things to keep in mind when, ways of talking to your patient, ways of informing them about their risk of a periodontal disease, diabetic connection, giving them those sound bites that they need, talking to them about the tools and the products that they can use to help reduce decay, help improve their oral hygiene, discuss the maintenance of the dentition, the reason why we want to keep our teeth, why it's healthier for us overall to have teeth to chew healthy food. I mean, it all is connected. And if we can find a good way of delivering that message in sort of a condensed, happy, non-judgmental way, helpful way, then, it usually resonates better with our patients. Stress meticulous oral biofilm removal as method of controlling the disease, and just talking to them about how much more imperative it is for them to stay on top of it, really, than, you can have tons of just kind of healthy patients that don't really have any risk factors, and they say, oh, I never floss, and their teeth look fine, and you're just like, dang it, I don't have anything to point to and be like, look at all this gingivitis, they get away with it, but patients with these chronic systemic diseases just don't get away with it as much. They just have to put in that effort, and it's going to benefit, both sides, the periodontal disease and the diabetes. So more with diagnosis and planning when the diabetes is controlled. So the good news is that if you do have a well-controlled diabetic patient in your chair, there's really not a lot that's going to look different. So that's the good news. If they're really well controlled, there's not very much that you have to worry about. They're gonna respond to the treatment. Typically, they're gonna respond to it in the way that you might expect. You still want to keep them, just if they're well controlled, they probably are aware of all these things and they're probably doing what they should be. So they're probably having, they're really fastidious about their oral hygiene care. They monitor their glucose levels, all these things. They may be using some extra products like fluoride or xylitol because they know they're at a higher risk for decay. So these are some things that if they're maintaining, take note of what they do, praise them and encourage them and congratulate them for doing what they're doing. And then these are some of the things that you would want to encourage for your uncontrolled diabetic patient. Frequency of maintenance intervals. I don't know if I have another slide for this or not. I can't remember. But very often, I'm just going to jump to the next one and see. Yeah, oh, okay, I do. All right, so I'm just going to go back here for a second. Oh, this is another thing. I was thinking, and maybe you guys who went to the IDC can tell me, I was thinking of having a diabetic educator maybe come in. I don't know, I wanted to do it this year, but I didn't know what was going to happen with COVID. So maybe next year or something, and they can come in and kind of give maybe a different perspective. But this is also a great time to collaborate. If you do have a practice where you feel like you see a lot of patients who have diabetes, you could reach out to a diabetic educator and talk to them and maybe get some pointers or tips on ways to communicate with your patients who have diabetes. And then, so evaluation and documentation, you want to document well-controlled diabetes typically responds well to SRP. We already talked about that. So in the evaluation period, if they're well-controlled, you would expect to see similar results as someone who's non-diabetic. If they're not controlled well, they probably won't respond as well as you thought they would. Delayed healing may indicate that they're hyperglycemic. Frequent recare intervals and frequent monitoring of the A1C is recommended. So a lot of my patients who are diabetic, I saw on a 3 to 4 month interval. And especially when I was working at the perio practice, everyone came in 3 to 4, but that was sort of a kicker. A lot of the patients that were that had diabetes, had periodontal disease, referred to the perio practice, and then we ended up seeing them every 3 to 4 months. Now that can happen in general practice too. You can just not refer them out, you just do it in-house, but it's very common to see them on a tighter interval. Carefully record all the data, treatments that are planned and performed, any relevant information, recommendations given to that patient. So you can kind of monitor, like if they're, I had this one patient that his A1C was always out of control and his periodontal disease was out of control. I was scaling like the apex of, I think it was, I can't remember now if it was 14 or if it was 3, but I was we were down to the end, and I was like, every time, and I'm like, you just get this tooth extracted. You wouldn't extract the tooth. I'm like, I'm scaling down at like the apex. I can feel it. And so it's, it's just, but you want to record all that stuff so that when you're not there, the next hygienist that sees them, they know that, that's something that was seen before. So in patients that have more complicated histories or, oral health or systemic health, you just want to make sure that you record all these things really well. Sorry, I was reading my notes here. What did I say? The short-term response. Oh, this might be interesting. The short-term response to non-surgical or SRP, like non-surgical periodontal therapy. So just your perio maintenance, in probing depths and bleeding on probing, attachment levels, and subgingival microbiota in patients with diabetes, it appears to be equivalent with the response for patients without diabetes, but people with poorly controlled diabetes have more rapid clinical attachment loss and compromised long-term response. So that's kind of interesting. So short-term, you might get some quick positive responses as alternative to it not responding as well as you think. You might end up getting it quickly, it looks okay, but then immediately it looks bad again. And they're like, I've been using my perio aid and I've been using my proxy brushes, but it just kind of goes back really quickly. And that's because they're just dealing with a whole systemic issue. So a little bit about hypoglycemia. So like we said, that was below 70 milligrams per deciliter, generally considered hypo. It's most common metabolic emergency in type 1 diabetes. So they'll have taken their insulin but not have eaten, or something else is going on. It results from an excess of insulin and glucose deficiency in the body. A blood glucose concentration of 80 to 120 is normal. We already talked about that. Each year, severe episodes affect approximately 20% of diabetics, type 1 diabetes. So that's pretty high. So it's fairly common. So that is the thing that you really, if you have someone that's type 1 in your chair, you really want to make sure they're feeling okay, doing okay, everything's on track. Minor episodes occur every 2 weeks on average in each insulin treated person. So they kind of, I mean, because it's such a serious thing, they might have these little moments of hypoglycemia that they can treat quickly. It might be a kind of a mini normal occurrence in their life, but we definitely don't want that in our chair. In patients with type 2 diabetes who are treated with sulfonylurea agents, hypoglycemia is more common. So just try and kind of maybe remember that the sulfonylureas, that's not the metformin. That metformin is the biguanides. So the sulfonylurea medications can increase the type 2 diabetics' potential for hypoglycemia. More common than is generally recognized, and it may be severe, especially among older patients. Alterations in dental hygiene care for older adults with diabetes. There's a good outline in your chapter. It's box 4914 that has a good outline just to kind of review. Hypoglycemia, signs and symptoms result from lack of glucose to the brain. And so the nervous system kind of overcompensates. So your brain's kind of starved, it's needing the glucose. And so your nervous system kicks in to try and compensate. That's why you get that shakiness, that anxiety, palpitations, that kind of cold sweat, very hungry, tachycardia, fast heart rate. And then kind of this sort of little bit of an altered consciousness or an altered state, might feel a little bit just kind of like weird aura. On unconscious hypoglycemia, patient, if they're unable to take, like, drink some orange juice or take the little gluca, whatever the tablets are, the glucose tablets, then of course, obviously you have to dial 911. And you guys learn that in medical emergencies, I'm sure. And what's that? Are you serious? What the heck? Okay, I'm done. Thank you. Thank you for telling me. I am the worst time manager. I want to end really early or make you guys go over. That's the last slide. It's about diabetic coma. You can look at it on your own. Thank you. I'm so sorry. Thank you for telling me. Bye, Avalon. Where's my recording?